Let's get started by thanking our wonderful sponsors who make this show possible every week. We can't thank them enough.
Macular degeneration is a leading cause of vision loss, with 15% of Americans being at risk or already affected. Scientific evidence proves that by using mesozeaxanthin, lutein, and zeaxanthin together replenishes the macular pigment and promotes healthier vision. This formula comes in only one product, MacuHealth.
Many patients come to my practice thinking they have to stop wearing their contact lenses due to dry eye discomfort, but that's not the case. With products and services offered through ABB Optical's dry eye portfolio, like Regenerize Light, a biologic eye drop, I can help patients manage their dry eye symptoms and ship dry eye products directly through ABB, allowing me to have happy, satisfied patients. Interested in learning more? Visit abboptical.com/dry eye. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Welcome back to part 2 of my interview with Dr. Art Epstein. In this episode, Dr. Epstein discusses the causes of dry eye and the newest technology to help in the diagnosis of this very ubiquitous disease. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. And please leave comments. How about LASIK?
Oh, it's I got an email today from someone on LinkedIn who is offering to help me promote LASIK in my practice, and I wrote back and I said, my practice is limited to dry eye and ocular surface disease, and I recently discovered, because we're doing a clinical trial and we needed to screen patients, that a much larger proportion of the patients that I thought had LASIK in my practice. It was an underestimation that a significant percentage of my patients, especially the patients in their, 30s, 40s, 50s, some in the 60s, have had LASIK. Again, we go back to the observation that the cornea has more nerves than any other tissue in the body. LASIK happens to make an incision along a plane where most of the nerves exist. So you're basically severing the nerve connections that eventually run through the eye, end up going through a nerve called the trigeminal nerve up to the brain, where there's a very large amount of processing that occurs, which then exerts control over these numerous functions that maintain the ocular surface. Now, some of the nerves recover in some patients, and they do okay. And some of the patients probably have redundant nerves, or the incision based on their prescription and the technique and the microkeratome or the laser, the femtosecond laser used, they don't lose as many nerves. But an incredibly large number of patients suffer from very severe dry eye because essentially the control mechanism has been destroyed. And since we lose nerves over time anyway, this is something that comes back stronger and stronger each year. So they start off with a little dryness, it gets better, they recover, and eventually they can reach a point where it becomes really problematic. So we don't co-manage LASIK. We don't advise LASIK. In fact, we recommend against LASIK. I think we'll look back at LASIK, even though we've solved many of the optical problems, as one of those things that maybe we should have given more thought to before we began slicing through the cornea. I'm sure I'm not going to make a lot of friends by saying that, but just from the risk of very, very severe dry eye outcomes, I would, and severe to the point of all of the problems you alluded to before, the psychological problems, the functional problems. My advice is generally think twice before you think of LASIK.
And you're a dry eye center, so you see some very tough dry eye patients who I'm sure had some severe side effects from LASIK.
Oh yeah. In fact, very early, I was not a big fan of LASIK, although I know this is going to sound strange, but I was a center director for TLC for a while. There was a point where I said, maybe I'm being too judgmental and just not moving ahead with technology. But over the and I was a very vocal advocate for patients who had been damaged by LASIK. I was on the board of Surgical Eyes, which was a foundation that was early on. And, if you search the internet, you'll see all kinds of interesting quotes of mine about, the dangers of LASIK and the, psychological impact. Most of those problems, not all, but most of those problems have been solved with, improved technology and better algorithms for treating the patients. But the dry eye issue, certainly has not. I understand why, some of my ophthalmology colleagues who do a lot of LASIK like it because, the patients are delighted with the visual outcome. But, that's not my area of concern. I have to deal with the aftermath in terms of dry eye. And it's a terrible, it's a terrible thing to have to deal with as a patient who's experiencing it.
How about meibomian gland dysfunction, the vicious cycle of dry eye?
Yeah, that's a great question. In fact, one of the big problems we have in dry eye is that there's so many different theories. In fact, I write a weekly editorial, as I know you know, and a couple months ago I wrote about how confused we all are because we have inflammatory dry eye and we have meibomian gland dysfunction and we have aqueous deficient and we have evaporative and we have lacrimal functional unit dysfunction and we have, there's a million and one theories, some of which are commercial in origin, companies trying to come up with rationales to justify the use of their medications or products or whatever. But a lot of them, are pieces of a puzzle, some cases big pieces and other cases very, very small pieces. And it's hard to recognize unless you're so immersed in it that that's all you do. And then you can kind of figure it out because you have to, that these pieces all belong there and they have to be placed in the right sequence and order. Meibomian gland dysfunction was first described in 1980, so we're I guess at the 40th, just past the 40th anniversary, by a brilliant colleague, an optometrist, Dr. Donald Korb, who's still active in Boston. I've had the pleasure of knowing Donald for many years and consider him a mentor. I certainly wouldn't be doing what I'm doing today, and many of us wouldn't be if it wasn't for him, his observational skills and his scientific acumen. And what he recognized in his particular case was that in contact lens wearers who would become dysfunctional, who would become intolerant, many of them had dysfunction or damage to these glands that are present in both upper and lower lid. They run radially up and through across, well, not across the lids, but down the lids on the inside, the innermost surface of the lid. And every time we blink, we pressurize them. We have little muscles that create that pressure. It's not so little. They're called the orbicularis. And the glands are sealed off by smaller muscles called the muscles of Reelin. And the pressure builds until the upper and lower lid hit and the little valves open and the oil inside is released and the upper lid as it sweeps upward spreads the oil to cover the entire surface. When it's working well, it's almost like taking a bowl of water. If you left a bowl of water on a table in Phoenix and came back a day later, it would have evaporated away. If you took a bowl of water and did the same thing, except took a bottle of Wesson oil and dumped half of it on top of the water, it would probably last for about 2 or 3 weeks. And if you dumped the entire bottle of Wesson oil, it would last probably for 3 or 4 months, maybe even 6 months, maybe even a little longer. The lipid, the oil, creates an evaporative barrier, and because oil sticks to oil, it creates surface tension and structure. Plus, the oils are very complex, so that some of the oils actually stick to the underlying moisture. Meibomian gland dysfunction describes progressive damage and loss of the glands, progressive dysfunction of the glands. You can have glands that are still present but not functioning. And this is something that we see increasingly more often because I think this is what's directly associated with modern times and computer use and visual tasking that most normal people go through. The people who sit in front of computers, the accountants, the computer workers, their meibomian glands begin to suffer. As the glands back up, the oil becomes more and more saturated. Eventually, the oil becomes rancid, so it gets from baby oil consistency to kind of a honey consistency to thicker honey to a pasty, eventually even a waxy consistency. Eventually it becomes rancid and the body sends in inflammatory cells to remove this rancid oil and unfortunately takes gland tissue with it. And then we end up with really end stage meibomian gland dysfunction or meibomian gland disease. And that in a nutshell is MGD.
Well, that brings us to inflammation. You mentioned it before. Do you think inflammation is the cause of dry eye?
No, that's a great question. Well, if you're a company that sells an anti-inflammatory, it certainly is. And if you are a clinician, it can be. And so what I mean by that, it's actually interesting. I think we're at a turning point right now. So a lot of people, for quite some time, because there was a tremendous amount of research and focus and lecture material focused on inflammation, some people still say dry eye is an inflammatory disease. We can even measure inflammatory markers. And the answer is yes, I think dry eye can be an inflammatory disease, but under two specific conditions, which is not a bad thing because frankly, if you are a company that makes an anti-inflammatory, either a medication or something otherwise that can reduce inflammation, it's still a tremendous opportunity because we have so much dry eye, quote unquote dry eye. So in the first instance, as I kind of alluded to before, homeostasis, or the body's intense focus on maintaining function and balance, works reasonably well for most of us most of the time until we reach a point where it doesn't. And when it doesn't work, finally the body is quite intelligent in its construction and design. Then the body says, hey, I can't manage this anymore, I need help. So it calls forth inflammation. And in fact, it does it in a number of different ways. It mobilizes inflammatory mediators or signaling molecules. So the rest of the body, particularly through the circulatory system, sends in T cells and eosinophils and so on. And that form of inflammation is somewhat problematic because, like all inflammation, once you open the door, it's very hard to close it. And that occurs in probably about 15-20% of patients. It's in the overall scheme of things. In addition to that, we have another maybe 10%, 8 to 10% of patients who, as we talked about before, have inflammatory systemic disease. And again, inflammation is non-discriminatory. It's a perfect example of the honey badger effect. It doesn't care. It just wants to get its thing. So rheumatoid arthritis may well present with severe dry eye and severe surface damage. That's usually a much more profound form of inflammation and much more difficult to control than the former, which is again a reactive form of inflammation. So overall, if you add the two together, you're probably talking at about maybe 20% of dry eye patients. Maybe if you really, depending on where you are and the type of environment, it might be as much as 25%. Which to me, again, if I was a company that made an anti-inflammatory, I would rejoice. That's a massive number of patients that can use an anti-inflammatory. We have two different types of anti-inflammatories. I should probably mention. We have the anti-inflammatories that are targeted specifically to dry eye. There is currently one approved by the U.S. Food and Drug Administration. It's called Lifitegrast. Its trade name is Xiidra, and it blocks T cells, which are inflammatory cells, from adhering to the surface. When inflammation occurs, one of the things that happens is a set of anchoring molecules are propagated on the surface. So you end up with an overexpression of this molecule called ICAM, intracellular adhesion molecule. And what this drug does is it kind of acts like ICAM without actually being attached to the surface. So it blocks the T cell's adhesion point, so it can't really adhere, and it shuts down inflammation. The second drug that's approved by the U.S. Food and Drug Administration just recently got approved. It's called Isuvis by a company called Kala. And what makes it interesting is that it is a traditional anti-inflammatory or a steroid-based anti-inflammatory, but it's the only one that's approved for the signs and symptoms of dry eye because it actually uses a technology that increases its effectiveness without increasing the concentration. making it a safe drug for limited use. Steroids should never be used for long-term use, even under doctor supervision, except in the rarest circumstances, and there are some circumstances where they should be. But this is designed for up to 4 times a day for up to 2 weeks use, and gives the patient control of their own symptoms. They consider it a rescue medication, which indeed it is, because it can shut down the inflammatory cascade. So those are two examples of modern state-of-the-art anti-inflammatory meds that work really, really well.
One of the strangest causes of dry eye is demodex. If you
Ah,
could explain that, and have you ever shown the demodex to any of your patients, any of those mites?
well, I'll tell you, the stuff of nightmares, my friend, the stuff of nightmares. So for your viewers who are not familiar with Demodex are what we call ubiquitous. It means they're pretty much everywhere. If you're over about 60, 65, nearly 100% of the population has Demodex. They're microscopic mites. They can be seen with a microscope quite easily. There's different forms of them. There's a follicularum and brevis, and probably other species as well. The entomologists actually categorize them by DNA, and they're not directly transmissible. In other words, you're not going to, get it from, kissing somebody. One of my earliest lessons in being cautious about what you say to a patient came when one of my patients had herpes of the eye, herpes of the cornea, a herpes infection, and I said, you have herpes, and many people immediately associate herpes with, sexual activity, which was not the case here. But he immediately, added 1 and 1 and came up with 8, and he said, he started to cry. I mean, he started to whimper. And I said, "What's wrong?" I said, "Don't worry, we can treat it." And he said, "I think I could have given it to my girlfriend." I said, "No, no, 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 you wouldn't have given this to your girlfriend." He said, "But we were doing butterfly kissing." And my mind started racing. I had no idea what butterfly kissing was at that point, and I thought it was something perverse or something that as a New Yorker being exposed to everything perverse, I thought I know everything, but I didn't know what it was. It turns out that it's fluttering your eyelashes together, which is, so I would have said, yeah, you could have given it to her. No, I wouldn't have said that. But so anyway, so I learned, that you have to be very, very careful. So when you say to a patient, you have Demodex, and you have these ugly mites, crawling around on your lashes. Some patients don't react well to it, so you have to be, somewhat gentle about it. I have never epilated a lash and shown that to a patient for the reasons I just kind of shared with you. However, and I will share this as an example of the modern world. I had a patient who came in who had self-diagnosed, courtesy of Google's assistance, that she had Demodex. And not only had she self-diagnosed, and she did have Demodex, by the way, which she proved both to herself and to me. She had epilated, removed one of her lashes, and used an USB microscope, which you can purchase on Amazon for, 50, 60 bucks, and taken videos of it. And she took out her phone and she showed me her own Demodex, which I thought, now suddenly
That's impressive. That's impressive.
no, the
That's
role was
impressive.
reversed. Suddenly I was grossed out by
Mm.
her Demodex instead of the other way around. So I said, yes, you definitely have Demodex, and we can manage it. So these days, sometimes you don't even have to do the patient's already figured out what's wrong. You just have to help them figure out how to fix it.
What do you feel is the best treatment for demodex?
Actually, there's something exciting coming. Tea tree oil has been in use for quite some time. We use a gentle form of it. Again, I have no financial relationship with IECO. I keep mentioning their products, but I'm not paid to do so. But they have a gentle tea tree formula, which is what we typically use. You don't really need a high concentration. A company called BioTissue makes something called Claridex, which is much stronger than that, and I think probably a little bit too strong. But there's a company called Tarsus, which is currently in clinical trials for a medication specifically for Demodex. my expectation it'll be out within probably a year. It targets the demodex as you would, any type of mite, very directly, very safe from initial reports. The data is very, very impressive, and I think that's going to be a game changer. Demodex, from a clinically relevant point of view, is underestimated in many patients, but overestimated in impact in others. There are obviously patients we could see on just simple examination have, a fair amount of demodex. They have these collarettes or cylindrical dandruff on their lash margins, plus they have irritation and other issues, and dry eye sometimes occurs with that as well. But for the most part, it's a silent disease. It should still be managed, especially when we have a new medication that'll do it safely. One of the issues with tea tree oil is a recent paper suggested that it can be toxic to the meibomian glands. Again, single paper, I'm not hanging my hat on it, but it's certainly something to consider.
Well, that brings us to technology for the eye. And one of our favorites is my meibomian gland, taking a picture of it, or my biography. Can you explain about that and the importance of it and how it could help us with treating patients?
Yeah, my biography is great. It's a great technology, and it's a very, very important technology, because otherwise you're trying to assess something. It would be like trying to determine whether a bone is broken without an X-ray. Certainly you can do that by palpation if you're a skilled palpator, but you're not going to know the extent of the break, and whether it's complicated, whether there are bone shards, and so imaging is extremely helpful from a diagnostic point of view. And as I mentioned before, this is a chronic progressive disease, and as patients lose more and more glands, the problem becomes worse and even more progressive. Plus, there are nuances in looking at the image. I remember I was on staff at North Shore University Hospital, which I think now is part of Northwell or some other big conglomerate, and we used to make rounds, occasionally with the residents. I was there, for every cornea clinic for many years. And I remember we would go to the neuro floor, and the neuroradiologist would look at, a brain MRI, and he'd be reeling off anatomy, and I'd be looking at it. It looks like a bowl of breakfast cereal. I couldn't tell the nuances, but I can look at my biography now, and I can, talk about, distal dilation of the ducts. I can talk about convolution, of the glands. I can talk about blockage, lost glands, inflammatory conditions. So there's a lot of subtle nuances that a good mybography device will reveal or unravel. In addition to diagnosing the condition and assessing the severity of it from a communications point of view, it's invaluable, because if I was a patient, and I had a problem, the more I knew about the problem, the more empowered I would feel to be able to address the problem, and the more I think comfortable I would be with the doctor who was sharing that information. It's a empowering two-way street. It's a bonding experience. My biography is a way of assessing the root cause of most dry eye, or certainly a major contributing factor. Technically, all it is essentially an imaging system that uses infrared, so that it highlights the gland and the gland structure, which is underneath a very, very thin layer of tissue on the inside of the lids. So the lids have to be everted or flipped. Those of you who went to high school with friends like I had in high school know what flipped lids look like, because I had friends running around scaring people in grade school and high school. But
There's
it's
always
not.
a kid in every class.
Yeah, there's always a kid in every class. Howard Morgan was my nemesis. I'm sure he's a banker today. I just have that feeling. But yeah, and patients get nervous about it. It's not painful, especially when a tech gets good at it. It's quick and simple. A number of good mybography devices on the market. There's the Oculus Keratograph 5M. There's the Antares from Luminous. There's I'm trying to think of, there's a bunch. I can go through an hour description probably to, for no real value, but we do have a lot of technology that's helpful. And some of it also measures other things like tear stability and, um, you know, what else? Lipid layer thickness in the case of the LipiView 2 from Sight Science. I'm sorry, Tear Science. So yeah, a lot of interesting technology.
At Allergan Eye Care, their goal is to protect and preserve vision. It's not just what they do, but it's who they are. They've been creating innovative products and services for providers and patients for over 70 years, and they continue to push the boundaries of what's possible in eye care each and every day.
Vision Edge gives you less eye strain and reduced damage caused by blue light. We like to call Vision Edge sunscreen for the eye. It all starts with your highest level of visual performance, only achievable through scientifically proven Vision Edge.
What percentage of gland loss do you think you need before dry eye gets so severe? Or you might start thinking about a scleral lens even, a special type of contact lens that's like a cup that holds moisture.
Yeah, that's a great question. I think there's correlation between gland loss and severity, but it's really interesting, Carrie. It's some patients are so stoic, they're almost martyr-like, where they absorb the discomfort and they don't want to bother the family or bother people with it. And you look at the glands. I had a woman on Tuesday who had virtually no glands. I mean, if she had 5% of her glands left, this was a 44-year-old woman, intense computer user, using, stuck in front of computers for many, many years, absolutely miserable. And you really had to tease away at it before she, really admitted to how miserable she was. I have other patients who have, almost normal looking structure, and yet they are horribly miserable. So it really is quite variable. But as a general rule, if you showed me my biography image, I could probably give you a reasonably good estimate of misery, especially if I had it combined with non-invasive breakup time, which is a measure of tear stability. The other, it's kind of the small elephant in the room, because very few people have this technology, is interferometry, which measures lipid layer thickness, basically the thickness of the oil slick on top of the tear film, the roof, if you will, the thickness of the roof. And interferometry for me is very, very telling, both in terms of how functional the meibomian glands are. In other words, how much lipid are they producing? Is there enough lipid to create a cohesive, coherent barrier? Number two, the quality, because it gives you an indirect measure of quality of the lipid as well. But we had a young girl who's probably, I would guess, maybe 14. Family was vegan for religious reasons, I believe. And so she was completely absent essential fatty acids from her diet, or, certainly EPA. And her lipid levels were, about 15 nanometers. Now, normal is probably about, 80 to 90 nanometers, would be ideal. So you're talking about almost no lipids being produced. And this kid couldn't even stare at a computer screen. I mean, that's how bad it was.
How about some advanced technology like a keratograph? What does that tell us?
Yeah, the keratograph, is kind of a Swiss Army knife. Again, the anterior is the keratograph. So it gives us meibography. We can use it for meibography. We can use it for non-invasive breakup time. We can, which basically is a measure of tear stability. It just measures how rapidly the tears begin to fall apart, and color codes it, so we can see, areas of red versus areas of yellow versus areas of green. We can measure tear meniscus height very easily. In other words, instead of having to do it in a slit lamp and estimate, or narrow the slit lamp, it literally, you can assess it very easily. Redness index is another useful tool to assess the aesthetic benefits of what you're doing. And it has a number of other things. It's capable of a measure of tear viscosity by looking at flow of particles within the tear. So these advanced instruments are expensive. They're not inexpensive. You have to, I think, be interested in dry eye and committed to it, to want to buy it. Although they do have other functions as well, which would replace other instruments. But they can be, for me, I would literally, it would be like flying a plane, with sitting backwards with my eyes closed if I didn't have the instruments. That said, there came a time a couple of years ago where I realized that looking at the patient and speaking to the patient gave me enough information to already have a good idea of what was going on and formulate a treatment approach with the equipment validating what my thoughts were successfully about 95% of the time. But without the technology, I probably never would have gotten to the point of Zen, where I was like, oh, I know what's wrong, So, that now at that point, it's great because now I can delve deeper. But sometimes the technology with that, the cancer patient I mentioned before, conflicting information, which led to literally a whole new way of looking at what I was doing, so it really is invaluable.
Are you a fan of dry eye questionnaires?
Uh, yes and no. It's like, I guess this is the time to fess up. Uh, now, I think when you're starting out in dry eye, as a clinician, I think dry eye questionnaires are very helpful because they're standardized. Typically what we'll use is a speed or an OSDI. And so it gives you a good assessment of the patient's experiences. As you become a more skilled examiner, it becomes good at documenting where they're at and then assessing the benefits of your therapy, because obviously if the patient's doing better, they're going to score better on the questionnaire. But I think when you get to this Zen point, just the conversation you're having with the patient, um, I grew up in a household where my father was kind of a very judgmental, kind of father. I mean, not judgmental in a bad way, but he seemed to know. He had a clairvoyant ability to know when I had a test. And he'd come home. So he'd say, "How did you do on your spelling test or whatever test I had?" And I was puzzled, like, how the heck did he know I even had a test? And if I didn't get 100, if I had like a 98, he would say, like, and it was worse for my brother. My brother's nemesis was a kid named Mark Levin. So he said, so he got a 98, huh? He said, so what did Levin get? And my brother would like, you hear like dog like whimpering. We didn't have a dog at the time, and he'd say, "You got 100, you got 100." And my father said, "You couldn't get 100." When I'd come home and I'd say, "Dad, I got 100." I wasn't I wasn't the older son, so I wasn't the favorite son. So he said, "Oh, so you had an easy test?" And I was like, when I took chemistry, he said, "Have you memorized the periodic table yet?" I said, "Why would I do that? It's a table." He goes, "What kind of course are you taking?" It's like, so, and it scarred me, it's like, so I never felt like anything I did was good enough, because it never was really good enough for him. So, I have a great tech, and I, and my text says, "Okay, patient's doing great. You work miracles. She's wonderful." And I'd walk in, I go, "Oh, so I hear you're doing really well." I'd look at the electronic health record, and I'd start looking at some of the data, and this creeping sensation is
Not
that
good enough.
overcame me. I haven't done enough. It's not, I haven't done it. And I started saying, "Okay, what are we going to do next? What are we going to do next?" And at that point, there wasn't a lot to do next because I'd already been successful at it. So I finally said, "Okay, this is craziness. This neurosis is was going to kill me." So I started asking patients, "Okay, on a scale of 1 to 5, with 5 being like super comfortable and 1 being absolutely miserable, it was actually 1 to 10, where would you be?" And most of the patients would say, "Oh, I'm about an 8 to a 9 now." So some would say they were 10, they were super comfortable, "And where were you when I first saw you?" And they would typically be, anywhere from a 1 to a 3. So after, about 2 months or 3 months of that, and I realized that most of the patients were, really doing well, I kind of, said, "Okay, Dad, leave me alone. I'm doing, I'm doing okay here." And then, I started to realize the easiest way to figure it out is, how are you feeling and how are you compared to when I first saw you? And I will tell you that, 98 out of 100 patients will say, literally no comparison. My life is completely different today than it was when I first saw you. They may not be perfect. They may not, I'm still not done, but, and that kind of really validated me. So, the question of using a questionnaire, for me at this point, we take questionnaires, we gather the information. I usually glance at them, but I don't really, absorb them. I'm much more interested in how the patient is doing, face to face, eye to eye, life to life, how they're doing.
How about tear film analysis, looking at the different strips, fluorescein, rose bagal, lissamine green? How does that help you? Do you use it?
Yeah, I do. I don't use lissamine green as much as I used to. I'll admit it. Still use it. It's we have it in the office, and I do use it. Fluorescein we use on pretty much every patient, almost every visit. Fluorescein, for those who don't understand what it is it's a molecule that fluoresces, that glows green. It's an orange dye that glows green when you expose it to blue light and energize it. And in areas that are damaged, it will absorb into the damaged tissue and it'll highlight the damage. So it basically makes, it enhances your ability to see surface damage and issues. Plus, it also mixes with the tears so you can see how stable the tears are. When patients have, clearly when they have a lot of fluorescein staining of the white portion of the eye, the conjunctiva of the eye, I typically will use glycerine green because often we get keratinization, basically skin-like changes of that tissue. The tissue becomes hardened, I guess is a good way of putting it, and the patterns are different. We see different types of damage, and it assesses different things. So we do use vital stains a fair amount. In fact, again with fluorescein all the time. I don't do Schirmer testing. Schirmer testing is taking a strip of filter paper and sticking it in the person's eye, usually with anesthetic, because it doesn't really tell me very much. I don't measure osmolarity except during clinical trials or really unusual cases. I think it's helpful. I think it'll be much more helpful when the Tear Lab, who manufactures the primary osmolarity device, comes out with their new discovery, which also measures inflammatory markers. And osmolarity becomes an analog or a surrogate for dilution, because knowing that there's inflammatory markers present in the tears doesn't tell you a lot. How diluted are those? How severe is the inflammation? That becomes much more important. And as you probably can tell from what I just said, I don't typically measure MMP9, which is a non-specific inflammatory marker. It doesn't take a lot of mental horsepower to look at an eye and go, that eye's inflamed. And getting a secondary non-qualified assessment isn't very helpful to me.
How about evaluating the lid position?
That's, yeah, it's funny. Yes. Lid closure and lid position is very important. And that's another example of you can save yourself a little bit of time by zoning in. Not that I don't check anyway, reflexively, but, in the conversation I have, typically I'll say to a patient, let's step through your day. When you wake up in the morning, is that the best time of day or is that the worst time of day? When a patient says, oh God, it's the worst time of day, I can barely get my eyes open, I know immediately that their lids are not closing properly. And that could be anatomical, it could be, post-surgical, it could be any number of things. But I typically will have the patient tilt their head back about 30 degrees, get down lower using a transilluminator, like a little flashlight, as you know, and then I'll look for glistening of either the white of the eye, the conjunctiva, or the cornea, depending on how their protective reflex works. I also look at just general lid position to make sure closure, apposition, health and quality of the lashes, and also lid margin, basically the flat of the lid, if you will, between the lashes and the eyeball itself. There's a flat portion, and I'm looking at the meibomian gland orifices. When we stain it with fluorescein or with lissamine green, we'll see a line called Marx's line, which can indicate, poor lid function, as well as looking for blood vessels, which would be indicative of rosacea or ocular rosacea, which is an important factor in dry eye. It's, a major cause of dry eye symptoms.
So let's turn our attention to management of dry eye. What is your first management? And I think I've heard you say this. You like to start off with omega-3s, that you feel that that's very important. So let's start with that. Tell us about omega-3s. How do you like to prescribe them? What ratio do you like to have the EPA to DHA? And is there a specific type, whether it's triglyceride or ethyl ester? Does it matter?
Yeah, yeah, and it's great. Talking to you, who I know is very knowledgeable in this area. Is great because I think a lot of people, and myself included, when I first started out, I was thinking, fish is a fish is a fish. Of course, go to Costco and get some fish oil. What's the difference? So, it's interesting. I approach things, very methodically. So yeah, almost structurally. So, and I tell patients we're going to start off with foundational or conservative treatment, and omega-3 fatty acids are number one on that list. In fact, I have a handout, a checklist that I give to every patient, and at the top of the checklist are omega-3s. And the reason why is, you have to look at cause and effect. Inflammation, to me, with the exception of the patients that have systemic inflammatory disease, is an effect. It's not. It doesn't cause dry eye initially, certainly not by itself, but it's an effect of a failure to maintain homeostatic control, so you get inflammation. Redness is not a cause of dry eye; it's an effect of, quote unquote dry eye, and I use quotes because it's not really dry eye. So irritation and burning, that's not a cause of quote unquote dry eye; it's an effect. But meibomian gland dysfunction certainly is a cause of all the other things. And, inflammation in patients with inflammatory disease can be a cause. Let's see what else. Um, Not managing flora, staph overpopulation on the lids is a cause and can be an effect as well. So I look at how can I make things work. Meibomian glands are probably the single most important aspect of normal function. Functioning meibomian glands make for a functioning ocular surface environment. And meibomian glands, in order to function, need certain raw materials, essential fatty acids, which are food elements that are not produced in the body but have to be taken in as part of our diet, which then do a number of things, whether it comes to building muscle or repair or lubrication or any number of other things. Well, the essential fatty acid, at least in my opinion, and based on some research that I've done, that is the building block of meibum, is EPA, eicosapentaenoic acid. That's what you get for having a long day. EPA is normally present in all fish oil products, and the ratio of EPA is very important because you need a fair amount of it on a regular basis. There was a study a number of years ago called the DREAM study that showed that omega-3 fatty acids in a decent form, and I'll explain that in a second, still didn't produce any greater benefit than olive oil did, which made absolutely no sense based on my experience and the experience of a number of other, friends and colleagues who are EPA, are omega-3 believers, if you will. So we actually, did a study because I was convinced that it was EPA that was the culprit. They use a 2-to-1 rather than a 3-to-1 ratio that I used. So we managed to get our hands on a pure EPA formulation. And of the 20 patients in this pilot study, 18 of them did not want to go back to the commercial product that we typically use. All of the readings that would be indicative of function, normalized function, were much higher with the pure EPA formulation than it was with the commercial formulation. So again, we couldn't, unfortunately, because of the cost of manufacturing a pure EPA supplement, we couldn't do that, certainly not alone, although I certainly tried. But EPA is to the meibomian gland what coal is to a coal stove. If you don't provide enough EPA, the meibomian glands are not going to function properly. And in fact, they'll start to shut down. And when they start shutting down, the oil becomes, increasingly saturated and eventually becomes rancid, as I discussed before. So omega-3s are number one. There are a number of products on the market that meet the minimum of a 3-to-1 EPA to DHA ratio. Those include PRN, physicians recommended nutraceuticals, DE3, and DE, which I don't know if they still make. DE3 is a 3-capsule version, and DE was a 4-capsule version. Nordic Naturals makes Pro EPA and EPA Extra, and they're all good products. different costs. PRN tends to be less expensive in my experience. And it's a very, very good product. There's another company, I think, called Unavis, that also makes a decent product. But patients that come in and say, "Oh, I take, Dr. Himmelbrand's fish oil, and it's recommended, Dr. Himmelbrand." I always tell them, if it was working for you, you wouldn't be here, because I think that is the single most important aspect in my bag of tricks. I tell patients that I was going to a desert island and I had one thing to take, it would be EPA. And the what you mentioned before, which is very important, is that most fish oils are not distilled down into or reesterified into a triglyceride or a natural form. They're basically brought to a plant, they're pressed, so the oils are collected, they're distilled by mixing them with ethyl alcohol, which raises the boiling point. The heavy metals drop to the bottom, mercury, lead, the PCBs, the light stuff boils off. The end of the still, you end up with an ethyl ester, which is why people complain of fish burps and indigestion. The fish fish in the form of an ethyl ester is not digestible by humans very much, so it's not very absorbable either. And some of the companies, like the ones I just mentioned, will re-esterify it or reprocess it to put it back in the natural form. If you were a bear grabbing salmon out of a river and eating it, you'd be getting a triglyceride form of the salmon oil.
Artificial tears. You go into the pharmacy, there's racks and racks of different types of artificial tears. Many patients come in with artificial tears. Like you said, if it was working, they wouldn't be coming in. But what's the role of artificial tears? The preservatives, there's ones without preservatives. Where do you stand on artificial tears?
Yeah, it's funny. There's a lot of companies that make artificial tears. There's a lot of good products. I certainly can't blame companies for being inventive and trying to invent a better mousetrap, if you will. So the artificial tears we typically gravitate towards today are tears that have oil components to them to supplement the lack of lipid produced in meibomian gland dysfunction, since that's the major cause. I know the literature, I didn't say this when we talked about meibomian gland dysfunction, but the literature says 80%, 86% of all patients who have dry eye have meibomian gland dysfunction. I think it's a gross underestimation. I think it's closer to about 97, 98%, maybe even higher. So, lack of lipid is very common. So we use products, Allergan's Refresh Mega 3, Refresh Active Advanced Mega 3, I always get confused by the name, is a non-preserved flaxseed oil containing supplement, and it's palliative. It will make you feel better for a short period of time. That just happens to be a really good formulation, very innocuous, no preservatives. For most patients, they can tolerate preservatives, especially the mild preservatives like Alcon products. The Sustain products generally have milder preservatives, which don't cause major problems. But if you can avoid preservatives, you're better off. Hyaluronic acid also works well. Oasis tears. I don't typically use a lot of it, but some patients like it, and I certainly have no issue with patients that use it. I tell patients the least important thing to me are artificial tears, and my goal is to have you come back at some point in the not too distant future and tell me that you're not using artificial tears. When a patient comes in and says, I'm down to, we've just done, IPL, and we've done this and we've done that, and they go, I'm down to I use artificial tears twice a week. I used to use them every 15 minutes. I'm now using them twice a week. I literally, rejoice, not because I hate the tears or don't want the companies to make money selling them, but it tells me that, their eyes are functioning normally and they don't need that additional supplement.
Hypochlorous acid has been popular over the last, I don't know, 5, 6, 7 years. Is there a place for that? Do you use that in your practice?
Yeah, it's actually number 2 in the ascent, the Epstein hit parade of dry eye products, and it's a very funny story with how this got started. Hypochlorous acid was invented. I forgot the name of the doctor. It was called not Ringers. I forgot what solution it was called, but it was invented by a doctor years ago as a surgical disinfectant. Forgotten about, pretty much. I mean, I think it was probably still used as a disinfectant. And a guy named Rhonda Jaffe, who had a company called Nova Bay, which was focused on non-antibiotic anti-infectives. He was looking at a number of different things, had a brainstorm, and he said, we have patients that have flesh-eating bacteria, and the reason why they lose their limbs is because the blood supply is destroyed, and white cells, inflammatory cells can't get into the tissue and shut down, the infection and the inflammation. And he reasoned that if you took what white cells produce to reduce the infection and infused it into the tissue, that you could shut down the inflammatory response and the melting or digestion of the tissue. And indeed, it worked. And in fact, you go on YouTube, you'll see, a number of YouTube videos that show how it's actually saved limbs. One of my really good friends who I had worked with at Alcon, which was a major eye company, on a number of projects, had moved to Nova Bay, and was working with Nova Bay. And he called me up one day and he says, "Hey, I'm now at Nova Bay." And I said, "Oh, that's interesting. Congratulations." He said, "We have this great new thing. It's an eyelid cleanser." And I immediately yawned and I said, Glenn, don't take this the wrong way, but eyelid cleansers put me to sleep. I think they're overused. I think the eye that has, blepharitis and inflammation of the lids and meibomian gland dysfunction, which we've been talking about, produces soaps naturally. So you're actually using a detergent. He said, no, this is not detergent. It's completely new and, whatever. I said, okay, fine. He says, let me send you, a dozen bottles, try it out. I trust your opinion. Anyway, he sent them to me, and they sat on my desk and sat on my desk and sat on my desk, gathered dust. My wife, who I practice with, who is a much smarter clinician than I am, and has I'm not just saying that, by the way, because she's, holding a gun to my head. She actually is really amazingly astute. And I'm away doing a lecture somewhere, and I come back, and she says, immediately I get accosted. It's not, "Hi, honey, how are you?" She said, "What the heck is that stuff that was on your desk?" I said, "What are you talking about?" She said, that eyelid cleanser stuff that's on your desk." It was called eyelid cleanser back then. So I said, "I don't know. It's an eyelid cleanser." So she says, "It's incredible. I'm using it on these blepharitis patients, and they love it. I want to order it, and I don't even know where you got it from and who it's from." Anyway, long story short, it's a big hit with blepharitis patients, and I reason that if it's working for blepharitis patients, it may work with meibomian gland dysfunction and dry eye patients. So I started using it tentatively, and lo and behold, it's almost miraculous. I mean, how much better they're doing. It took me a while to reverse engineer exactly what was happening, but when patients have meibomian gland dysfunction, it changes the microbiome, basically the flora, the bacteria, the population on the lid margins, and you end up with an overpopulation of staph bacteria. Staph are normally present and they keep worse bacteria away, so they serve a good function. But when you have too many, they do what bacteria do. They continue to grow. They produce toxins, which keep other bacteria away, but we're sensitive to, which causes red eyes and irritation. And they produce digestive enzymes, which all bacteria do as well. The digestive enzyme that's the problem is called lipase, which breaks down lipid. Since the tear film structure and the evaporative barrier is made of lipid, when lipase gets into the tear film, and you blink a little bit and you have salt in the tear film, you create soap, which we see as frothing or saponification. And soap breaks down the tear film even more. When you spray in hypochlorous acid, it A, kills bacteria, B, inactivates the toxins, and C, deconstructs the digestive enzymes, which it naturally does, because that's what it does when the body synthesizes it in white cells in order to fight infection. So we figured that out and we started using it. So I consider hypochlorous acid to be an integral part of managing dry eye patients, because almost all of them have overpopulation of staph bacteria because of alterations in the normal bacterial population in the lid. So simply spraying it on the lids, blinking to spread it, and then allowing it to sit for about 10 seconds and wiping it off can be game changing. And it's very rapid. The omega-3 takes 6 to 8 weeks to kick in. The hypochlorous acid is almost instantaneous. Within a day or two, they'll notice a massive difference. So very, very important that people begin to embrace that. Some of them, by the way, have too much bleach. It can be irritating, but some of the more popular brands, Avanova's, Nova Bay's Avanova is a good brand. High Clear is a great brand, very stable product, and several of the others that are available are quite good.
So does blink training really work?
Actually, no, 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 no. Actually, it's funny. We just revised our instruction sheet, which I almost wish we did, because like literally every 3 weeks something new comes out, and I have some other brilliant idea. But we put on the back of it our blink training form. I'm not even sure. I think my wife managed to get the original version of it, and it looks like something we smuggled out of the Ukraine in the 1930s. These round-faced people blinking, and I explain it to every patient. I read the salient paragraph, which is close your eyes, or blah blah blah, and it originates from Donald Korb. He was the originator of the concept of blink training, which I think was probably associated with rigid lens wear back in the day, the old hard lenses, and then when he figured out meibomian gland dysfunction, it kind of eventually resurfaced there. Now, the reason why blink training is important, the reason why I explain to patients that they should do it, is because it establishes normal muscle memory. And I'm not, I grew up in, I tell patients, I grew up in New York City, so I'm not holistic. I'm not like a Californian, who, grew up on granola and listening to, Peter, Paul and Mary or whatever. I'm kind of a nuts and bolts kind of guy. But the reality is it turns out I'm all outcomes focused. And in this situation, the blink is the most effective way of pumping the lids and expressing meibum. It was designed that way. Whether it was a supreme being who calculated the angles, or whether it was evolution and nature, doesn't matter. It works very effectively. So if we can restore normal function, then you actually will start to resume normal production of lipids. So I reinforce blink training. Now I recognize that, and I say, don't do it in the car, you'll get into an accident. Don't do it in front of people, you'll get institutionalized. But because it's bizarre looking, this constant weird blinking. I say you don't have to do it every 20 minutes. You can do it every half an hour, even once an hour. But I want to restore normal muscle function. So I do think it has an important role. Some of them are religious about it. I do think there is some correlation with success. And I do think if we can get something to work naturally, rather than, having to do a procedure, for $1,000, the better, so blinking is important.
And how do you tell them to do it?
I give them a sheet, and I basically read, I think, paragraph 3. So I mean, and it's, I don't demonstrate. I know some people, demonstrate that they, go through the motions, but I've spent so much time with the patient at that point. The typical new patient has, at least 45 minutes of my time, if not longer, depending on what I have afterwards. And, if it's a budding lunch, I'll sometimes go even, an hour and change. And, part of that is, instructing how I want them to use things, what I want them to use, complications. I'm very big on, describing how medications work. I think the more you understand, the more connected you are to the process of getting better. So, getting into the mechanics of blink training, I'd probably look like a big goofball. So I don't want to go down that road.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.